لا بعد.
لازم نفتح المحاضرة أول شيء. الآن
اي واضح الآن.
Okay. So what is the background? Now after we have two these autoimmune disorders. So we have environmental factors as well as genetic factors, same like rheumatic fever. So not all children who have streptococcus infection, they develop glomerulonephritis. Now what will happen after the bacteria enter the body? There will be a formation of the what we call the antigen antibody complexes between the streptococcus and between the antibodies of the human being. This antigen antibody complex will deposit in the glomerulus. So this is the first mechanisms. So there will be inflammation in the glomerulus and the increase of the inflammatory cells. And it is post-infectious, that means after the bacterial infection. The common age actually between 4 to 12 years. This is different between nephritis and nephrotic. Nephrotic syndrome occurring actually at younger age than the nephritis. Male to female ratio is almost equal. It's not much difference actually. Slight difference, slightly more common in you can say in the male comparing to the female. And prognosis is good. This is the structure of the kidney. This is what we call nephrons. Starting blood vessels coming to the nephron, we have afferent and efferent. The afferent is coming from the body going to the glomerulus. انتوا شايفين الماركر؟ Hello?
اي واضح.
اي واضح.
So this afferent and this efferent. This is the glomerulus. We have proximal convoluted tubules, then lobe of the Henle, and then distal convoluted tubules, and then the collecting duct. So this is what we call the nephrons. The disease which affecting the glomerulus or nephron, this is actually nephritis or nephrotic syndrome. There are other group of disease affecting the convoluted tubules, either proximal convoluted tubules or distal convoluted tubules. This we call renal tubular acidosis, either distal or proximal. Proximal we call Fanconi syndromes. Also, we have disease affecting between the nephrons, and not here, the cells between the nephrons, we call interstitial nephritis. Also, there are disease which are affecting the juxtaglomerular apparatus. There is apparatus here, cells which are producing hormones, اللي هي aldosterone or angiotensin. That's different disease, like Bartter syndrome. So today we are going to speak only the disease which is affecting the glomerulus itself. Now this is the structure of the glomerulus. This is the afferent coming to the glomerulus and this efferent. If you take cross section of these vessels, we have like this one, okay? So we have three layers. The first layer from inside, it's actually endothelial. And then we have basement membrane. And then we have epithelial layers from outside. So after the fluid will come, the lumen of these capillaries, it will pass to the space here. This is the space of Bowman's capsules. This Bowman's capsule have parietal and visceral. This the parietal is from outside, and the visceral consists of these layers. After that, the fluid will go from Bowman capsules to the proximal convoluted tubules, and then to the lobe of the Henle. So this is what we call filtration of the blood to make milk. Now, where is the disease? In the case of post-streptococcal glomerulonephritis. This mechanism, the first mechanism, the antigen antibody complex form in the blood, it will come here through the capillaries and they will deposit along this basement membrane. So you can find just below the epithelial cells, there is immune complex deposition. The second mechanism, there's antibodies directly react with this membrane. We call antibodies against the basement membranes. So this is the triggering factors. After that, there will be proliferation of the epithelial layers as well as proliferation of the endothelial layer. This we call proliferative glomerulonephritis. Now, not only the epithelial layers actually increase, also the endothelial cell increase, also mesangial cells. This is called mesangial matrix. Mesangial matrix consists of mesangial cells and there's also connective tissue. So this is mesangial matrix between these. So in some disease, also mesangial cell increase, and if it's IgA deposition, we call it IgA nephropathy. In IgA nephropathy, you'll find there's IgA deposition within the mesangial cells. In nephrotic syndrome, like minimal change, we'll take in next lecture, there will be fusion of food process. This is epithelial cells containing a food process is long. So fusion of these food process together lead to the abnormal filtration. This is what we call minimal change nephrotic syndrome. So we have different mechanisms. So in post-streptococcal glomerulonephritis, there's antigen-antibody complexes come and deposit along the basement membrane just below the epithelial layer. Any question about this?
Clear.
واضح لي.
Okay, so this is another slide. What's same? This is the efferent blood vessels. This is the mesangial matrix and mesangial cells. And this is the cut in the capillaries of glomerulus. And as you can see here, we have endothelial layers, and we have basement membrane, and we have epithelial layers, and we have food process. These are actually part of the epithelial layers. This is what they call the juxtaglomerular apparatus. This is just the structure of the cells near the glomerulus. This we call juxta. Juxta means near the glomerulus. This is actually responsible for formation of the hormones like aldosterone and angiotensin and so on. So it's actually different. Okay. Proximal tubules are here, and disease of proximal tubules can produce renal tubular acidosis or Fanconi anemia. Now, what is the infiltration? What is the filtration barrier? The filtration barrier, the structure consists of three layers: the endothelial layers, the basement membrane, and the epithelial layers. Any disease of this can affect the filtrations. So this is the mechanism: either streptococcal antigens trigger antibodies. These antibodies can directly react with glomeruli. It's called antibodies against basement membrane, anti-basement membrane. The second mechanisms, we have immune complexes, which are filtered by glomeruli, and then they deposit in the glomerulus just below the epithelial cells. What will do? What is the problem with this immune complex? This immune complex actually activates the complement system. What are the complement? These are the small proteins produced by the liver. And when the immune complexes activate these complements, this will release what we call inflammatory reactant. And this inflammatory reactant lead to the damage to the glomeruli. So this actually acute phase reactant, same like cytokines and other reactants. So they can damage the glomeruli. After damage of the glomeruli, there will be decrease in glomerular filtration rate, and which lead to the mainly because of damage of the basement membrane. So GFR, which is glomerular filtration rate, will be reduced. Reduction to glomerular filtration rate lead to the decreased formation of the urine, and the patient may develop oliguria and other problems. But in the disease of glomerulonephritis, as I mentioned, the tubular function is preserved, so you don't have renal tubular acidosis or loss of the electrolytes through the renal tubules. Also, the plasma renin aldosterone system also preserved because you don't have disease of the juxtaglomerular apparatus. Now, what are the clinical manifestations of glomerulonephritis? This slide actually can explain. Mainly, the child will have hypertension, will have pre-orbital edema. The urine color will be red color, or sometimes they call brown, dark brown, or coca color. These are different names of this urine. And if you examine the urine, you'll find it's a cast. What is the cast? Cast بالعربي يعني قالب. So if this cast containing RBC, we call RBC cast. يعني هو عبارة عن قالب تكون موجودة فيها خلايا دموية حمراء فيسموه RBC cast. It may contain protein. Normally, there is protein. We call hyaline cast. Iron cast containing protein. If containing WBC, we call WBC cast, and so on. So in case of glomerulonephritis, we have RBC cast in the urine. Throat examination, you can find inside enlarged tonsils and follicles of pus. If you do throat culture, you'll find the streptococcal bacteria. This is triggering this inflammation. So it's autoimmune disease, not because of direct infection with bacteria. So there's interval between tonsillitis and between nephritis. This interval could be a couple of weeks, not necessarily immediately. Okay, same like rheumatic fever. Now, what is histopathology? If you look for the glomerulus, you can find there's inflammation within the glomerulus, so the epithelial cell number will increase. Also, the number of the endothelial cells also increase. The other problem you may see, there's inflammatory cells within the glomerulus, like pus cells. This is actually neutrophils. These neutrophils actually pus cells. Okay. You also find there is RBCs within the glomerulus. So in the lumen of the capillaries of the glomerulus, this is the capillary cross section. You can find these increased inflammatory cells as well as RBC cells. The mesangial matrix, for simple glomerulonephritis, mesangial matrix is okay, but there are other types of glomerulonephritis. You find also the mesangial cells also increase, and there is maybe deposition of antibodies زي في حالة IgA nephropathy. In IgA nephropathy, you can find the increased mesangial cells and also the IgA deposition within the mesangial matrix. What about basement membrane? A simple post-streptococcal glomerulonephritis, the basement membrane is not affected. The other disease, the under membrane of pleurative glomerulonephritis, the basement membrane also get thicker and abnormal. Okay, this slide explains to us about the incidence and the spectrum of the changes. So we have post-streptococcal glomerulonephritis. It's formed the majority of cases of the word post-infectious, that means after infection. So not necessarily we have streptococcus, we have other organisms, but the streptococcus is the main organisms. Almost half of the cases actually because of streptococcus. Sometimes you have other organisms like staph, gram-negative. It may occur also because of bacterial endocarditis or shunt infection. This can also produce glomerulonephritis. What is included in your curriculum is actually the first one. You should know about this one. The other one, just you should be, and for your knowledge, and you should know that other organisms can also produce post-infectious glomerulonephritis. Symptoms starting with fever, headache, malaise. Fever, not necessarily at the beginning, because as I mentioned, because of the autoimmune, because of the previous throat infection. So fever precedes actually the nephritis, maybe 1 week before or longer, okay? But these are, the other are present during the presentation to the nephrology clinic. The patient will have headache, usually because of high blood pressure, malaise, that means the patient looks completely tired, fatigue, anorexia, decreased appetite, nausea, vomiting. Pallor can occur because of anemia or because of edema. Child may be confused because of high blood pressure. Lethargic, that means not active. Hepatomegaly, again because of maybe associated heart failure. So these are the symptoms. What about signs? If you look to the urine, you'll find the urine color is dark brown or a smoky urine color. This is actually present in almost in 1/3 of cases. So there will be gross hematuria almost in 1/3 of the cases. This is opposite to the nephrotic syndrome. Other thing, you will have oliguria, that means decreased urine output. So urine be less than 400 ml per day. Edema around the eyes mainly, we call preorbital edema. In severe cases, you may have also edema in the lower limb as well as upper limb. But generally, edema is only around the eyes. So in 85%, you have edema around the eyes. Okay. High blood pressure. almost 80% of the children with nephritis, they have high blood pressure. Could be mild, but sometimes even moderate. Any questions so far?
Clear, doctor.
Right.
Clear, doc.
Child may develop convulsion in 10%. This because of very high blood pressure. Okay. Now, are all children with nephritis, they develop only this picture? A small percentage of nephritis, they can also go to the picture of nephrotic syndrome. So this, if both together, we call nephrotic. So in other words, we have maybe only nephritic, or only nephrotic, or nephritic. So typically, post-streptococcal glomerulonephritis, they have only nephritic. Small percentage, they can also develop picture nephrotic, then we call nephrotic. And usually those develop nephrotic not because of the streptococcus, because of other reasons we are going to explain later, okay? Again, a small percentage, they can develop renal failure. The majority of the cases of post-streptococcal glomerulonephritis, they have good prognosis, they improve by time, but small percentage, they can develop renal tubular damage, renal glomerular damage. So because of this, they can develop renal failure, called acute renal failure. Okay. What is the causes? Thrombosis in the small capillaries of the glomerulus. Other complication, severe hypertension can produce encephalopathy. This we call hypertensive encephalopathy. The child will be drowsy, be confused. So we have this one of the emergency condition we have to manage immediately. They may develop heart failure. They may develop pulmonary edema. This is actually not rare. It can happen because of high blood pressure, okay? In severe cases. So although prognosis is good, but the child may present very seriously. Now, if you want to examine this patient, first of all, you have to look for the state of the patient, starting with vital signs and temperature, heart rate, blood pressure, saturation. As we mentioned, high blood pressure, one of the features of this disease. Look for the core peripheral temperature. You know what is core peripheral temperature? Anybody? Core اللي هي الcentral body temperature you take from the rectum. Peripheral, this is actually from the skin, so you will take from the axillary. So this is not less reliable. Core temperature is more reliable, okay? In severe illnesses, there will be difference between core and peripheral temperature, like heat stroke, for example, like heat exhaustion. In this case, though, so we are relying mainly on the core temperature in case of severe cases. We have to also take the weight, height, and put on the charts. It's important to take weight because we want to know whether the patient has fluid retention or not. Those who have renal failure, there will be increased fluids in the body, so weight will be increased. The state of hydration, you're looking for the peripheral perfusion, which is capillary fill. Usually the patient not in shock, but very severe hypertension, there will be decreased perfusion because of spasm of the blood vessels. Also, are looking for the jugular venous pulse in the neck. This look because we want to assess the fluid overload in the intensive care unit, looking for the edema. So this is actually important. And then look for the signs of heart failure, like hepatomegaly, tachycardia, tachypnea, gallop, and also the cardiac enlargement, displaced apex speed, okay? Look for the signs of the multiple system disease because post-glomerulonephritis, we don't have other system involvement, but if you have nephritis for other reason, for example, like SLA, then you may have also skin rash, joint involvement, oral lesion. So differential diagnosis of the post-glomerulonephritis is other cause of nephritis, like systemic lupus erythematosus, for example, hepatitis B or hepatitis C. So we want to make sure that we are dealing only with post-streptococcal, not with other type of the nephritis. Palpation of the kidneys, bladder is important. If you have large kidneys, again, in case of nephritis, kidneys actually may be just palpable, but if very large kidneys suggest other causes. Bladder enlargement suggesting fluid retention, so maybe you are dealing with other problem as well. Now, what is nephrotic syndrome? This slide actually shows the difference. Now, in nephritic syndrome, we have mainly hematuria and proteinuria, but proteinuria is mild in case of nephritic. Okay, oliguria, that means decreased urine output, hypertension. In case of nephrotic syndrome, problem mainly is proteinuria. We have very high protein in the urine, which is more than 40 milligram per meter square per hour. This is how to measure. And next slide, we can explain how to measure the urine, how to measure the protein in urine. I mean, in next lecture. Also, nephrotic syndrome, you have high decreased albumin in the blood. We call hypoalbuminemia, okay? So less than 25. Normally, it's supposed to be around 35, between 30 to 35. So here, we will less than 25. We will have edema, marked edema. And you have high lipids, hyperlipidemia. So here, the picture of nephrotic syndrome, and here the picture of nephritic syndrome. If the child has both, then we call nephritic. In post-streptococcal glomerulonephritis, you have only the picture of nephritic syndrome. Now, nephritic, what is the causes? In nephritic, mainly we have post-streptococcal glomerulonephritis. That means after the streptococcus infection. Sometimes other organisms like the staph, okay, post-staph glomerulonephritis. In nephrotic, the commonest cause for children is a minimal change nephrotic syndrome. That means there is abnormality in the food process of epithelial cells outside the basement membrane. Triggering factors, different triggering factors, we're going to speak about the next lectures. Okay, perfect. So this is what we call mixed type. Mixed type, that we may have both together, which is rare, but can happen. Okay. Now, regarding the investigation, we'll start with CBC, looking for the evidence of infection, like leukocytosis. We have also to look for the other element, like platelets, for example, and WBC, because if they are affected, then may consider could be patient has systemic lupus erythematosus, SLE, rather than post-infectious. ASR may be elevated because of infection. Coagulation screen, اللي هي الPT والPTT والbreathing time, supposed to be normal في nephritic, but they are abnormal for nephrotic syndrome, and also could be abnormal for SLE. Looking for the electrolytes like urea, calcium. طبعا creatinine, urea may be increased if there is oliguria and decreased renal function. Not classical, but those who have nephritis, they may have also high urea and high creatinine. Other elements usually normal. Liver function, bone profile, all are normal, except if nephritis because of SLE or for other reasons. Look for the albumin. We said albumin could be low if you are dealing with nephrotic syndrome. Also, you have to look for other like calcium, magnesium, alkaline phosphatase. Now, if you do blood culture, usually negative because you are dealing with autoimmune disorders. But if nephritic because of staphylococcus or other organism, then you may have positive blood culture. This is important about complement. Now, classically in post-streptococcal glomerulonephritis, you have decreased C3. Okay, so C3 will be decreased, one of the complement, and it's remain low for a couple of weeks. The other, like C4, are usually normal. Okay, now if they are low, then they suggest that it is nephritic because of other reasons like systemic lupus erythematosus. What about IgA? Again, IgA here is normal for post-streptococcus, But if you're dealing with IgA nephropathy, then IgA will be affected as well. Now you have to look for the evidence of the streptococcal infection. So you have to look for the ASO titer and anti-DNASB. Now in post-streptococcal glomerulonephritis, the ASO titer will be elevated as well as anti-DNASB, and they remain high. If they are low at the beginning, you want to double check, you have to measure after 2 weeks, because it may could be low initially, but after 2 weeks it will be increased. So this suggests the patient has acute infection with the streptococcus organisms. Other antibodies we do only to exclude other cause of nephritis. Patient coming with nephritis, you want to make sure it's not SLE or other connective tissue disorders. So you can ask for the antinuclear antibodies, double-strand DNA. You can ask for the other rare antibodies, like antibodies against space membrane, and so on. These are antibodies against the basement membrane. We call antibodies against space membrane. This can produce also nephritis, one of the autoimmune disorders, different than post-streptococcal glomerulonephritis. You can do throat culture looking for the bacteria, streptococcus, in the pharynx. You can do skin culture if the patient has a skin rash, suggesting cause of post-streptococcal glomerulonephritis. So this post-streptococcal glomerulonephritis can follow either throat infection or skin infection, not necessarily throat infection. Now in urine, important to look for urine analysis, looking for the what? You are looking for the cast, RBC cast, looking for protein and looking for the blood. I mean hematuria and proteinuria and RBC cast. Want to exclude any associated infections like UTI. You want to look for the electrolytes in the urine. And you can also measure urine excretion of sodium, what we call fractional excretion of sodium. So we measure in the urine sodium and multiply by creatinine in the plasma, divided by sodium in plasma, multiplied by creatinine in urine. So this will give you a ratio what we call fractional excretion of sodium. In other words, how much amount of sodium is excreted in the urine. This actually helps to assess the kidney function. You want to differentiate whether it's kidney renal failure because of perirenal or renal or post-renal. You have to do fractional excretion of sodium, and you can assess the kidney function. Okay, you can do renal ultrasound, looking for the size of the kidneys, and rarely you have to do renal biopsy. Now, renal biopsy only want to confirm the post-streptococcal nephritis, and we rarely do if you just think this patient has post-infectious nephritis. Okay? But if you think this patient has other types like membranoproliferative glomerulonephritis or crescentic glomerulonephritis, then we have to do renal biopsy. So in post-infectious, we don't do, but in other types, we can do it. In other words, if the patient has these indications, then we may have to do renal biopsy. And if we do renal biopsy, we may find the patient has either membranoproliferative or crescentic glomerulonephritis. So what are the indications? Patient who has severe renal failure at presentation. Patient who has rapidly progressive acute renal failure. So these actually both suggest the patient may have either crescentic glomerulonephritis or membranoproliferative glomerulonephritis. Patient has atypical presentation. Patient who have delayed atypical presentation, for example, nephritic and nephrotic together, for example. Patient has delayed recovery. That means hematuria still remain even after 1 month. We are speaking about macroscopic hematuria. That means you can look to the red blood by eyeball, okay? So more than 1 month. Or the patient has low C3 for more than 6 months. So all these actually indications to do renal biopsy. And if you do renal biopsy, you may see the patient has either membranoproliferative or crescentic type of glomerulonephritis. Last indication, patient who has heavy proteinuria for more than 6 months. Because heavy proteinuria more than 6 months suggests actually patient has not only nephritic, he has also nephrotic element, nephritic together. Differential diagnosis of nephritic syndrome, we can make 2 groups. First group, with low complement, second group with normal complement. So nephritic syndrome with normal complement, these are the differential diagnosis: hemolytic uremic syndrome, IgA nephropathy, Henoch-Schlein and Purpura, Alport disease, and simple nephrotic syndrome. So in all these conditions, we have normal complement level. HUS will take in PED2, IgA, men in medicine actually. We can touch just briefly HSP in PED2, and Alport, I think Dr. Salma, she's speaking him.
عذرا بس الميتنج
أيوة.
بيقفل، اتوقع نفس الرابط بيكون شغال. اذا ما اشتغل
نخرج
لا
ندخل.
لا هو بيطلعنا، بس اذا طلع اتوقع نفس الرابط اللي ارسلت لك اياه بيكون كويس.
كم دقيقة باقي؟
less than a minute الحين.
طيب معناته ندخل أحسن.
تمام.
Low. So I have to differentiate between nephritic syndrome. Now, what about the management? Patient should be admitted because this patient has conditions could serious. Okay. First of all, you have to treat any underlying infections. So it could be streptococcus. So you have to cover with antibiotics. Usually give oral penicillin for at least 10 days to eradicate any remaining organism in the throat. And these antibiotics, even if throat culture is negative, better to give because throat culture is not always positive. Okay. If you give antibiotic, will not prevent glomerulonephritis because, as I mentioned earlier, it's autoimmune. So maybe infection already occurred 1 week before, or 1 week or 2 weeks before arrival to the hospital. However, we want to eradicate any remaining bacteria in the throat. Then we have to give loop diuretics if the patient has decreased urine output, or if the patient has edema, then we have to start Lasix to decrease the fluid in the body. We have to also measure the urine output input because we don't want the patient has fluid retention and secondary heart failure. Now, patients usually have hypertension, as we mentioned, about 60 to 80%. They have high blood pressure, not necessarily severe, could be mild to moderate. Okay, so if mild to moderate, we can give simple medication like nifedipine. Nifedipine is calcium channel blocker. Okay, but if the patient will have very high blood pressure, then we have to give other medication in the ICU. So nifedipine and hydrazine is commonly used, but those who have very high blood pressure, we have to give nitroprusside or diazoxide. This is actually given by the infusion to prevent hypertensive encephalopathy or to treat hypertensive encephalopathy. Sodium should be low in diet, so restrict sodium diet. And also don't want to give excessive fluid unnecessary because lead to fluid overload. Protein, actually, if the patient has decreased urine output and there is high urea and high creatinine, again, we have to reduce the protein. Now, patient should be in the bed rest during the acute inflammation. After that, we allow him to move gradually. Once the patient starts to improve, progress in general is good in these patients, okay? Only less than 1%, they may develop pulmonary edema and severe pneumonia and can lead to mortality. Less than 1%, they can progress to kidney failure, chronic kidney disease. So in general, it's good prognosis, okay? You have to follow the patient carefully for many reasons. One of them is hypertension. Other reason, patient who have hematuria, proteinuria, and renal function and edema. So the patient who has gross hematuria not resolved, need to follow up carefully. Usually gross hematuria take less than 2 weeks. Complement take less than 2 months. Proteinuria improve within 6 months, okay? Macroscopic hematuria will take longer time. So we have to follow this patient for these problems. If persist, we have to worry whether the patient is going to develop renal failure, chronic renal failure, or develop nephrotic syndrome. This is the slide showing Alport syndrome. Now, Alport syndrome could be autosomal dominant. Okay, here, as you can see, it's actually autosomal recessive carrier. The mother is carrier, and you have 2 children affected. Okay. Here also you can see there is a sex-linked. Only the male affected actually. The females are not affected. Okay, so it could be autosomal dominant, could be autosomal X-linked. So now, what are the features? You have dysmorphic features, as you can see. There's the downward slanting of the eyes, upturned nose, depressed nasal bridge. It's rare syndrome, but can produce hematuria, can produce nephrotic picture, can produce proteinuria. It also produce problem in the eyes, what we call anterior lentoconus, اللي يسموه بالعربي العدسة المخروطية. Okay? Can produce retinopathies. They can produce sensorineural deafness. From kidney point, we are concerned because these children of Alport syndrome, they can come to you with hematuria. So one of the differential diagnosis of hematuria is Alport syndrome. May come to you with proteinuria, okay? Especially in X-linked type, they may develop hypertension. إذا إحنا خلصنا المحاضرة هذه على الوقت، في باقي عندكم محاضرة ثانية اللي هي نيفروتيك سيندروم، تكون بعد الظهر إن شاء بعد التراويح إن شاء الله.
إن شاء الله.
أي سؤال عن المحاضرة هذه؟ الأشياء اللي ما فهمتوها في أشياء حتتكرر مرة ثانية في المحاضرة اللي بعدها، فممكن نراجع بعض الحاجات اللي قلناها. يعني في تداخل بين النفرتيك والنفروتيك، فأنا ركزت على النفرتيك I spoke small things about nephrotic syndrome, but maybe next lecture will make things more clear to you إن شاء الله.
إن شاء الله. الله يعطيك العافية.
تمام، يعطيك العافية دكتور.